Deputy Director Tuberculosis. The team from Central TB Division, our case presenters, Dr. Venkata Rajiv, our case expert, Dr. Mary, state expert, Dr. Sumanlata, all the state TB officers, district TB officers, faculty from medical colleges, medical officers, and all the distinguished guests, a very warm welcome. I'm Dr. Neeta Singla. I'm Nodal Officer, DRTB Center at NITRD. To my right is Dr. Rupak Singla. He is consultant in the Department of TB and Respiratory Diseases. To my left is Dr. Saroj Meena. She is a senior pulmonologist at NITRD. Now I request our director, Dr. Manpreet Bhalla, to deliver her introductory remarks.
Good afternoon, and I welcome everyone on behalf of NITRD for today's session of Difficult to Treat TB Clinic. And also I would like to welcome DDG-TB, Dr. R.P. Joshi, who is always present here to motivate us, and he makes it a point to be present for all these meetings as usual and encourage us. I also welcome Dr. Katoj, who is a senior microbiologist, and he has joined today. Dr. Bhardwaj, who is the chairperson of the National Task Force. So just to give a brief about this clinic was started in August 2020, and it was started with partners like CTD, great initiative of Dr. Singla and other directors, earlier directors of NITRD. So as we all know, this is a case-based, difficult to treat TB clinic, and it is we hold it in order to disseminate the knowledge about the NTEP guidelines, and we want to reach all over India. Like all the partners here are the medical colleges, DTOs, STOs, the teachers, colleges, and students. So all are involved, participate in this meeting. Also, experts in the field are invited to discuss about the national guidelines. So whatever the latest guidelines are existing, and to disseminate these guidelines among all the people, stakeholders in the TB field. So also, we are trying to we want to include all our DNB students, PGs, and all. Also, they should be involved in this initiative, and we will. I think they will. We are maybe joining, and we want to make this as a part of the academic activity of our institute for the students. So I would also request Dr. Bhardwaj to encourage all medical colleges to join and participate in this TB clinic. So once again, I thank everyone for joining and participating in this difficult to treat TB clinic today. Thank you.
Thank you, Dr. Manpreet. Thanks a lot. Now, before I invite our DDG, sir, I would like to introduce the team for the day today, sir. So today's clinic is a very special clinic because it is being presented by Mamta Academy of Medical Sciences, Telangana, which is a private hospital and medical college, and they have their own DRTB center. Dr. Venkata Rajiv, Assistant Professor, Department of Pulmonary Medicine, will be presenting the case. Dr. Mary Moses, who is the Associate Professor, Department of Community Medicine, will be the case expert. So they maintain an excellent coordination with the government centers there. And we have Dr. Sumanlata, the state TB epidemiologist from STDC Hyderabad, who will be the state expert. The national expert for the day is Dr. Ishanand, who is a renowned neurologist and professor of neurology at Gangaram Institute of Medical Education and Research, Delhi. Sir, a very warm welcome to the team. And today's session is a very successful model of public-private mix. We are also joined by many faculty and students of medical colleges. Today, we are also joined by the students of our own DNB course. So I welcome you all. A very special welcome to Dr. Katoj, who has joined us after a long time. Welcome, sir. So over to DDG, sir, for introductory and opening remarks.
Good morning. Namaste. Very good initiative, which is helping all doctors across India. See, to start something is not easy, and to sustain it year, month after month at very high quality, and with such an interesting combination that a lot of people join and make its utilization. Even now, I see that the number has already crossed 275 participants. So it is a real pleasure, and I thank Dr. Singla, Madam Singla, and all the team which are doing it very well. On behalf of Central TB Division, it is my pleasure to invite and thank Dr. Katoj sir, who has been the doyen of tuberculosis in the whole India to this. And we also have NITRD Director, Dr. Balla Madam, then NTF Chair, Dr. Bharadwaj, and many other very senior people who have been guiding force of TB program in India. I also take this opportunity to thank and invite Venkata Rajiv of Mamta Academy and case expert Dr. Mosi and state express Dr. Sumlata and the national express to this very, very important meeting. So, and most importantly, I thank all the participants who are joining month after month, which actually motivates all of us to do this activity in a continuous manner, regular manner. So thank you all, and looking forward to learning from this. Thank you.
Thank you so much, sir. Thank you for your consistent presence and insightful words. They are a source of motivation for the TB fraternity here. Thank you, sir. And we start the case now. Over to you, Dr. Venkatraji, for case presentation. Dr. Venkatraji. Yeah. Thank you. So your slides are still small. Do we present from here?
Ma'am, am I audible, ma'am?
Yeah, you're audible. Yeah, they're better. Yes.
Yeah. Can I start the presentation?
Sure.
Good morning, everyone. Good morning, everyone. I'm Dr. Rajiv, Assistant Professor in Department of Respiratory Medicine from Mamta Academy of Medical Sciences, Bachpally, Hyderabad. So today we're going to present a case of a 17-year-old college-going female who has presented with slurred speech and vomitings for the past 5 days. A multidisciplinary approach has clinched the diagnosis. Coming to the details of the case, patient is a 17-year-old female hailing from Nizampet, Hyderabad, who has presented to the emergency room with the following complaints: headache for 5 days and vomitings for 5 days. Patient was apparently normal 5 days back when she developed headache, which was insidious in onset, severe, diffuse, throbbing type, and associated with photophobia. Patient also had vomitings, 2 to 3 episodes per day, which were projectile, non-bilious. Vomitings were not associated with abdominal pain or nausea. Patient also complained of myalgias and generalized weakness. In the ER, patient had slurred speech. Patient could comprehend to what is being said, but could not verbally respond. So, coming to negative history, there is no history of fever, no history of seizure activity, or no history of loss of consciousness. There's no history of tingling or numbness, no history of any trauma to the head. There's no history of any cranial nerve or sensory or cranial nerve deficits. There's no history of any involuntary movements, or there's no history of incontinence of bowel or bladder. Now, with this history, come to the in the general physical examination, patient was drowsy but arousable, conscious, coherent, moderately built and nourished. Her vitals were stable with pulse rate 72 beats per minute, respiratory rate 18 per minute. Her BP was 130 by 70 mm Hg, right arm supine position, and her saturation was 97% at room air. coming to the systemic examination, her respiratory system was normal vestibular breath sounds were heard, bilaterally equal. CVS S1, S2 were heard, per abdomen soft and non-tender. Her CNS examination, patient was drowsy, had slurred speech, no signs of meningeal irritation were present. Pupils were normal, reacting to light. So with this examination, the neurology consultation was sought. The neurologist has come up with these differential diagnoses. So either it could be stroke or it could be a cardioembolic stroke with underlying rheumatic heart disease or infective endocarditis, or it could be due to infections like disseminated tuberculosis or disseminated fungal infections, coccidioidomycosis or histoplasmosis, or could be due to a vasculitis headache, either due to SLE, systemic lupus erythematosus, or an ANCA-mediated vasculitis. So these were the differentials. With these differentials, the following investigations have been advised: MRI brain with contrast, CSF analysis, ANA profile, C-ANCA, P-ANCA, and ophthalmology examination, HRCT chest. So these are the investigations advised by the neurologist. So a contrast MRI was taken, and these are the findings in the contrast MRI. So here we could see left frontal lobe, which showed a diffuse T2 flare hyperintense cortical thickening. So, and also in the subcortical white matter, there is patchy T2 flare hyperintensities which are present. Now this is again the right frontotemporal area where we could see in the cortico-subcortical junctions 3 to 4 mm sized T2 flare hyperintense ring enhancing lesions at the cortico-subcortical junction, which are suggestive of granulomas. Here again in the left frontal lobe, we could see leptomeningeal enhancement, which is suggestive of meningitis. Now, with these findings in the MRI, an ophthalmology examination was sought. In the ophthalmology, here with the ophthalmoscope, these are the findings what the ophthalmologist could report. There are ill-defined, pale yellow, ill-defined, raised subretinal opacities, subretinal lesions, which are found in the superior quadrant of the superior temporal quadrant of the left eye. With this, a pulmonology consultation was sought because a pulmonology consultation was sought at this time. Now, when the pulmonologist could see, this was the X-ray. So the X-ray was the findings are, we can see this is the AP view of the patient. We could see costophrenic and cardiophrenic angles are normal, bilateral diaphragms shadows are normal, extrathoracic soft tissue is normal, trachea is central, upper and lower mediastinum are normal, rib cage is normal. Coming to the parenchyma, we can see not tiny faint nodular opacities, which could be noted in bilateral lower zones. Now, with this, this was around third day of admission, and here we could see these are the reports which are available to the pulmonologist to see. The tuberculin skin test, which was done initially, now that had showed no induration at the end of 48 hours. The CSF analysis had come. The CSF analysis showed total number of cells were 5, 100% neutrophils, 100% lymphocytes, 100% lymphocytes, and no neutrophils. There were no granulomas or malignant cells, and it was clear CSF fluid. So with this, any 5 or more than 5 is considered significant. So with this, coming to the biochemistry, the proteins were 66.8. Anything more than 15 to 45 is normal, more than 45 is exudate. So, and sugar is 49. At the time of examination, at the time of analysis, the GRBS which was taken was 106 milligram per deciliter. So 49 is less than 2/3 of the normal glucose level. So with this, raised lymphocytic exudative CSF with low glucose is evident, but the CSF ADA is less than 10, which is 3.69. So with this conclusion, it was not completely fitting into tuberculosis or So a diagnosis of either a fungal infection or because it is lymphocytic and low glucose, a fungal infection or a tubercular infection was first in the differential diagnosis. So with this, a HRCT chest was ordered. So this is the HRCT chest. This is the image of the HRCT chest where we could see now random nodules scattered diffusely in both the lungs could be seen. Along with it, in the middle lobe, consolidation can be seen. Also consolidation can be seen in the lingula. In the mediastinal window, we could see a right paratracheal lymph node. So this is the CT report. 3 to 5 mm size random nodules are present diffusely in both the lungs. Consolidation is seen in the middle lobe medial segment, also in the lingula. In the mediastinal window, both upper and lower right paratracheal lymph node cellulars, largest measuring 20 into 18 mm size. So with this, so here for the miliary nodules, a differential diagnosis, as we know, disseminated tuberculosis, disseminated fungal infections because of the short history was initially made as a first differential diagnosis. After that, bronchoalveolar cell carcinoma presenting with miliary nodules was the second differential diagnosis, and rarely ABPA and pneumoconiasis were also a part of differential diagnosis. And with this, bronchoscopy was planned. The bronchoscopy was done on the next day. So this is the bronchoscopy notes. Bronchoscopy was done through the right nasal cavity under local anesthesia. 2% lignocaine was used. The findings are vocal cords were normal, moving equally. Trachea was normal. Carina was sharp. In the right main bronchus upper lobe, all three segments could be visualized. They are normal. Secretions were found oozing from the right middle lobe medial segment. So from right middle lobe medial segment, bronchoalveolar lavage was taken. Around 80 ml of normal saline was instilled with a 20 cc syringe, where 20 ml each was given, and 20 ml of lavage fluid was withdrawn. After this, transbronchial lung biopsy was performed from the right lower lobe. Total number of 3 biopsy bits were taken from the right lower lobe, posterior basal segment, and lateral basal segment. A cupped biopsy forceps was passed through the posterior basal segment initially. It was passed till the resistance was attained. After that, patient was asked if she could feel pain. When she felt pain, the forceps was withdrawn 1 centimeter into the bronchoscope. Patient was asked to exhale completely. Patient was asked to hold in exhalation. There, the biopsy was taken. So with this method, 3 biopsy bits could be attained, and after the sample was satisfactory, a procedure was stopped. Complications of the procedure: a patient had pain for around one hour after the procedure. This was managed by giving medication. After the bronchoscopy was done, a check X-ray was taken, and they did not show any pneumothorax. So with this, here are the reports of the bronchoscopy. So bronchoscopic cytology. Now the cytology showed moderately cytosine smears are moderately cellular with macrophages, lymphocytes, squamous epithelial cells, and columnar epithelial cells. The smear is negative for AFP. Zn stain of the smear is negative for AFP. It reported an acute inflammatory smear. The histopathological examination of the biopsy taken is here. Grossly, they reported that they had 3 bits of biopsy which was found, measuring 0.5 into 0.4 into 4 centimeters. So under microscopy, they could see the smears. It showed strips of respiratory epithelium. The biopsy contained a collapsed lung, and within the collapsed lung parenchyma, they could see granulomas. Granulomas consisted of epithelioid histiocytes and Langerhans giant cells. Central necrosis was also found in the granulomas. So a diagnosis of necrotizing granulomatous inflammation was given. Zn stain of the biopsy was negative. Fungal stain, which was asked, SM stain was also negative. So with this, a pathological diagnosis of necrotizing granulomatous inflammation was given. So the microbiology of the bronchoalveolar lavage, which had come in 2 days, the gene expert MTB of the bronchoalveolar lavage showed mycobacterium was detected, which was low. Rifampicin resistance was not detected. The CSF, which is also sent for gene export TB, CSF, which is also sent for MTB, it detected very low. MTB was detected very low, and rifampicin resistance was not detected. FLLPA, first line LPA had shown there is no resistance in INH and rifampicin. I forgot to show. These are the images of the histopathology. This was under 40x, where we could see the respiratory epithelium and granulomas. And in the magnification 100x, here the granuloma very clearly visible. So with this, a diagnosis of necrotizing granulomatous inflammation with gene expert showing Mycobacterium tuberculosis. So a diagnosis of miliary tuberculosis was made. So and it is drug sensitive because gene expert showed no resistance in rifampicin, and the first line LP also showed no resistance for INH and rifampicin. So now, what are the risk factors for developing disseminated tuberculosis in such a young female who was apparently normal for 5 days back? So the risk factors usually for disseminated tuberculosis are malnutrition and immunosuppression. So her urine sent for ketone bodies was positive. Her HbA1c was 5.3, which showed she was not a diabetic. Her immunoglobulins were sent to show if she has any immunodeficiency. The immunoglobulins were normal, and she was negative for HIV and HPC, HIV 1 and 2. So the only thing what we could found was that she had ketone bodies positive in her urine. So with this, the final diagnosis made is disseminated tuberculosis with miliary tuberculosis and tubercular meningoencephalitis. So treatment, patient was started on ATT under NTEP. Her weight was 59 kilos. She was started on fixed drug combinations, 4 tablets per day before breakfast. She was also started on steroids, 0.5 milligrams per kg per day. 30 mg of prednisolone was started, and also on pyridoxine supplementation, or 20 mg at night. With this treatment, patient received this treatment for 2 months. And here we could see her HRCT test after 2 months. Now, there is significant resolution of the random nodules, which we had seen 2 months earlier in the previous CT. And also, but the mediastinal lymph node was persisting, which is around 20 to 18 mm size. So this was the CT report after taken of 2 months, which showed nodules again. The nodules were present, which did not totally disappear. It also consolidation, which is there previously, is not there, and the mediastinal lymph node, upper and lower paratracheal, is still present, which the size of it is around the same, 20 into 19 mm. So with this, her intensive phase has been extended by 1 more month. So she has given 3 months of intensive phase, and though her steroid could be tapered over 3 months duration. So her headache also has come down after stopping the steroids at 3 months. Patient is now presently on continuation phase. Question to the experts: how do we manage miliary tuberculosis and TB meningoencephalitis? What is the regimen, and which is the best, and when do we alter the regimens? Thank you.
Thank you, Dr. Rajiv, for an excellent presentation. So we open the forum for any questions on history of this patient or investigations. Dr. Rajiv has all the investigations available with him. So if you have any question or queries, we can take up those questions.
Yeah, good morning. My name is Dr. Vijay Kumar from Hyderabad. I think the presenter has done a very good job of thoroughly investigating. And about 35 to 40 years ago, because I have been practicing for the last more than 40 years, when we saw the miliary TB, we never had the opportunity to do such an extensive investigation. And at that time, the diagnosis was mostly based on excluding the other similar looking issues like lung cancer, lymphangitis, carcinomatosis, metastatic cancer, pulmonary hemosiderosis, sometimes hypersensitivity pneumonitis, and importantly, other infections like histoplasma, blasto, nocardia, sarcoid, etc. And of course, looking for other manifestations of miliary in the eye, the CNS, the skeletal system, the lymph nodes, and abdomen to look for lymph nodes. And two very important comorbidities we used to look at was diabetes and HIV, because they can really pose a lot of challenges for the treatment. But otherwise, miliary has to be treated as an extrapulmonary presentation and to be treated as such for at least a minimum of 9 months of the regular treatment. And here, in this case, we have no doubt at all, since the CBNAT has come positive, rifampicin resistant is not seen. So I think we should proceed with the usual way. And rightly, corticosteroids have been started because they are indicated in miliary. One of the reasons that is mentioned is adrenal apoplexy, because this miliary tubercles can be there in the capsule of the adrenals, which can produce sudden hemorrhage causing adrenal apoplexy, also known as Waterhouse-Friderichsen syndrome. And they need aggressive treatment with steroids. But otherwise, I think I would congratulate Rajiv for bringing up a beautiful case,
Thank you, sir.
thoroughly
Your
investigated.
comments are well
Thank you.
taken. Dr. Rajiv, there's a question on chat which is asking, can you share the IGRA report? Do you have a IGRA report?
IGRA was not done, ma'am. MAN2 test was done. MAN2 test showed, it was displayed in the slides actually. I'll show it. I'll share my screen and show it.
So just tell us the report. You need not show it. Just tell us the report. What was the report?
No, the report says no induration was noted. So you can see the report on the top. No induration was noted after 48 hours. Now it is visible. There's no induration.
Dr. Rajiv, in this patient, we seen that there was a ketonuria present. So did we follow up the patient for the cause of ketonuria because HbA1c was also within normal? Right?
Yeah, ma'am. So I was about to say it. So this patient actually was on a diet. So we took a thorough history as why she had developed miliary tuberculosis without any comorbidities. So I will share the screen here. So this patient, it is written here, this patient was actually on a diet for around 1.5 months. Now, after that, she had her engineering exams for which she was sleeping only 3 to 4 hours in the night and she was studying. So now irregular or sleep deprivation and malnutrition, both are risk factors for reactivation of tuberculosis as it is there in our literature. Now these are both there in her, and and also she had a history of common cold which she developed 10 days prior to coming to the hospital, which lasted for 2 days, and she also had dry cough for 2 days. So I think a viral infection on top of malnutrition and on top of sleep deprivation, these are the conditions which actually made her prone for such grave presentation of tuberculosis.
Yes, so ketonuria may be due to starvation as she was fasting also, like on diet for the plan.
Yes, yes.
Are there any questions on diagnosis? As far as diagnosis is concerned, then we discuss the treatment part. But anything on diagnosis? Any questions on that?
There are questions which are not related to the case per se, But how do we diagnose genitourinary tuberculosis? Like this is a case that, so we'll take it later. This question we'll take it later.
I'm Dr. Ish Anand. Can I analyze the case from the neurological point of view?
Welcome, sir. And just let me tell everybody, sir, Dr. Ishanand, sir, is the national expert for the day, and he's a renowned neurologist at Sir Gangaram Hospital in Delhi. Yes, sir.
So, like you see, this is a sort of a patient who is young and a very short history, 5 days history, and without any fever. Like normally you expect fever, headache, vomiting, alteration in sensorium at the like when these patients present to you, especially the patient who have a meningitis. Tuberculoma is a different thing. Like in tuberculoma, the patient may present only with a seizure or headache without any fever. And we have seen in practice many times these patients are taking analgesics or they are taking antibiotics. So the history of fever may not be there. And then this patient has very rapidly gone into altered sensorium. Mostly you see patients who have been on treatment for months together. Like earlier they are treated as a viral fever, then somebody will treat them with the enteric fever, and then they will come to us and we will diagnose them having TB meningitis. So these are a few peculiar things about the presentation. But if we see, this was a meningoencephalitic presentation presenting with the headache, vomiting, altered sensorium, and there was some focality into it. The focality was the speech being involved. So this is from the history point of view. If we come to the diagnosis, if we see the scan in the MRI scan, we are seeing a lot of meningeal enhancements. Like you can see in the sulci, where like you can see the blood vessels are very prominent at that area, and you can see the tuberculomas are very next to, like these are they're just forming there at a very early stage, and there are sort of multiple of them. We could see only one image in that one axial section. We could see a lot of tuberculomas at the gray and white matter junction. This is the site they begin with initially. And if they burst open into the meninges, then that causes meningitis. So this patient didn't have any neck stiffness, but had meningismus, or patient had photophobia. So that will again suggest involvement of the meninges. If we see the CSF, in the CSF, we do not see too many cells. I think there are only 5 cells, all lymphocytes. The sugar is not very low. The protein is high, but again, it's around 60, not that high. ADA is not involved. But then the TB gene expert or the TB net is positive, and that is what we have found to be very useful. Like in the last 8 to 10 years, this is what we have available at Gangaram Hospital. So that is, and many a time when we come across these patients in whom we do not get any positivity in the CSF, we always go for a CT chest and abdomen. And we try to always look for the bacteria, and we always look for the resident. Because working in a tertiary care center, it is very important to know the rifampicin resident or the ionized resident in the beginning. Because you may end up giving them primary anti-tubercular treatment, and later on they may turn out to be resistant to rifampicin. So our aim is to find out the bacteria, find out the sensitivity. And in most of the patients, if we are not getting a diagnosis from the brain, we either do endobronchial biopsy from the mediastinal lymph node or an ultrasound guided biopsy from the mesenteric lymph node to reach the diagnosis. And should we discuss the treatment part?
With the permission of the chair, can I add a comment?
Yeah.
We discussed about the association of HIV and diabetes with tuberculosis, but now there is a new comorbidity or coincidence, and that is young women and women premenopausal who want to lose weight. They are getting into a lot of different kinds of keto diets, which is producing a sudden drop in the calories and sudden drop in their cell-mediated immunity. And the latent TB, which is there in most of these people, the bacteria starts multiplying, producing a very extensive tuberculosis of a very sudden onset, which includes miliary. So it's a good thing that Rajiv has taken a detailed history, and that uh, attempt to lose weight in a rapid phase these keto diets is definitely linked to this. That is the reason why we see the ketones in the urine, and it's a very, very important coincidental finding for a new acute tuberculosis.
Thank you, sir. Thank you. Now I request our case expert, Dr. Mary Moses, to give her comments.
Unmute.
So by the time Dr. Mary is joining, we'll just discuss the treatment once ma'am has given her comments. Ma'am, you have to unmute yourself.
Good afternoon, all. In view of like multidisciplinary approach in a young college girl, this 17-year girl has presented with an acute presentation of slurred speech, headache, and vomitings. Actually, with thorough history and examination, and with the involvement of multiple departments in our medical college like general medicine, neurology, taking neurology opinion and ophthalmology examination, and with the help of radiological findings, and mainly the pulmonologist Dr. Rajiv has done the thorough investigations, and he started on treatment, and we were in the follow-up with the case. And after 2 months, we could do the repeat HRCT, in which we can see the resolving findings. But though the findings are not completely resolved, we thought to extend the intensive phase for 1 more month. And we have provided her on intensive phase for 3 months. And here the key point which we would like to highlight is, like, though we have studied the presence of comorbidities and all, which, as the experts has already mentioned, the role of keto diet and all, which is also positive in this case. We should able to, as TB is a social disease, and many clinical socio-demographic factors play an important role in development of tuberculosis, mainly in the disseminated tuberculosis. We should completely look for the social and other demographic factors which play an important role. And apart from that, most important thing is which is on rising health consciousness, which is leading to sudden presentations of disseminated in developing countries like India. So here to conclude, as a medical college, as a the involvement of multiple departments, we could identify the disseminated tuberculosis case in a very less period. And one more thing, we would like to thank NITRD and also state expert Dr. Sumlata ma'am for giving this Mamata Hospital for this opportunity to share our cases on the national platform. Thank you all.
Thank you, ma'am. The STDC West Bengal has raised his hand.
Good afternoon, ma'am and sir. It is indeed a very good case, but I would like to know that seminar was performed from CSF and bronchoscopy material. So for the presentation is concerned. Now, it was shown in the presentation that 3 bits of samples from bronchoscopy was put in the formalin. So whether that formalinized specimen yielded CBNet result. This is my first question. And second thing is that in both cases we have seen that the TB-MTB load was very low. So it is our practical experience that in low TB specimen, the signal intensity of LPA is not good. So it will be very, I will be happier if we could see that first line TB LPA bands, or it was processed through liquid culture. Thank you.
Thank you, sir. I'll request Dr. Singla to take this question about how to transport the sample to the lab.
You see, first of all, as the point has been raised about which sample to be collected in a suspected case of TBM. If you go by the literature, the CSF has got very high sensitivity. I think the highest among all the EPTB cases. So CSF must be sent for CBNet because it can clinch the diagnosis and also can tell us whether there is rifampicin resistance or rifampicin resistance is not there. First line LPA, because of the low bacterial load in these cases, may not be positive, but yes, better to send it for at least to know about the INH resistance data. Second is, in this case, the bronchoscopy had been done, and fortunately, the bronchia respirate, it showed MTB detected low. And when the LP was done, again it shows MTB detected low. So normally when there is a low, very low, we have slightly less doubt that whether it is really TB or not. But once two methodologies, that is CBNet and the LPA, show MTB detected low, there should not be any doubt that we are dealing with the case of tubercle meningitis. And regarding the transport, we must see that it is transported in a cold chain and transport as early as possible, especially in these cases of EBTB where it can be life-saving. So one should coordinate with the center where CBNet is being done so that we do it early and we have a diagnosis early. And may I request Dr. Kadoch also, he is a known microbiologist, and I think he should be speaking more on this rather than me. So sir, please, your valuable comments.
Dr. Singla, I don't have any very specific comments because the case has been investigated in a very equal manner. Only point arises, that this kind of expertise which was available at that center will not be available elsewhere actually. So how far the algorithms which are clinically, you correlate everything, and with the method which are available. So how in such cases with such a short history of 5 days, and somebody totally getting into a acute stage. I think that's something is to be taught to the people. But microbiologically, you won't be able to do much. I tell you, it's only if you have a facility, you can get the specimen, you can do it. You must do it if you can do it. But here they could correlate everything: the image, the granuloma presence, then also the microbiological. So everything led to a confirmation of diagnosis. But I don't think many people will be lucky that way. I think that's the question: is the clinically the fastest that suspicion said. I think that should be the emphasized one rather than the investigation. I'm telling you, because I certainly, even being a old microbiologist and a molecular biologist also, I will not preach for looking for the technology. That's a question of access. I will not be a supporter of that. If it works, it works. If it doesn't work, you should not. You should not make that as emphatically as a point of investigation. Actually, if it's possible, it's possible. Yes. Thank you.
Thank you so much, sir. Thank you for your comments. Can I request Dr. Ishanan to talk about treatment in this case now? How this patient should be treated?
Yeah, we have the TBNet positive, and it is sensitive to rifampicin. So we are thinking it is a bacteria which is sensitive to the first line, and we have a option of starting either with EHRZ or SHRZ. Because ethambutol, especially in the patient who have opticochiasmatic tuberculosis or the patient who have raised ICT, were a bit scared about starting ethambutol, and in those cases we go with streptomycin with the arsenex, INH, and pyrazinamide. And another option, sometimes we see we do add sometimes levofloxacin or moxifloxacin also. Like it is a case in which like there is very florid tuberculosis, you're seeing a lot of granulomas and you're seeing a lot of aggregates in the basal system. Sometimes we do go with even 5 or 6 to begin with, even in the patient who have a sensitive tuberculosis. But most of the time, it is either ethambutol or streptomycin with the 3 main drugs. And then we continue like normally it is 2 months, but most of the time I continued with for 3 months. Then I repeat a scan and then see the response. Those are recommendations are more frequent scans actually if you see. But most of the time we go with 1 scan, and that if the patient is doing very well, we go with another scan after 3 months, looking for the response to the treatment. And then again, one has to be aware of the paradoxical response. Sometimes you will see granulomas which were not there appearing or seeing more aggregates coming up. But at that time, you go more with the clinical outcome or the clinical response to the treatment than changing the anti-tubercular treatment or adding some other anti-tubercular treatment. After most of the time, after 3 months, I stop ethambutol and I continue with the rest 3. And TB meningitis is an easier way to disease to treat. I complete 1 year of ATT, in which I give pyrazinamide for around 9 months, and then continue INH and rifampicin for 1 year. So this is what we do. I do in TB meningitis. Though the treatment of tuberculomas is a bit different like that, because tuberculomas may persist for a very long time, and in those cases we do MRI brain with contrast every 3 months, and the meningeal based granulomas or meningeal based lesions may continue to be seen even after 3 years, 5 years. So there sometime we end up giving treatment for 1.5 years. Then steroids. The steroid definitely have a role, and we use dexamethasone more than prednisolone. And the dose is we use it 0.3 to 0.4 mg per kg body weight to begin with. Most of the patients will receive 4 mg 3 times a day or 6 mg 3 times a day till they are admitted. Most of the time for 2 weeks, and then we taper it off over the next 3 months. But the patient who have arachniditis, like or the patient in whom, like sometimes we continue with the anti-tubercular treatment even up to steroid even up to 6 months, gradually tapering them off, because that arachniditis part is very difficult to handle or difficult to treat. And in the patient who have arachniditis or the patient who have opticochiasmatic tuberculosis, hyaluronidase with the hydrocortisone is an option which we use sometime. But most of the patients who have arachniditis, severe arachniditis, it is very difficult to instill these medications in those patients. But in a normal patient like this 17-year-old girl, I think 1 year of the treatment should be sufficient. And we are like looking for the side effects because ethambutol is causing optic neuritis, or streptomycin giving hearing difficulty or imbalance is very important in the neurological patients. So that the treatment for TBM is 1 year with steroid for 3 months. If it is tuberculoma, then we follow it up for 1.5 years. And if it is severe arachniditis, then most of the time it is 1.5 years with steroid going even up to 6 to 9 months.
Thank you, Dr. Ish. We all know you are a known neurologist of the country, and you are working in a Gangaram hospital, which is the tertiary care referral center of Delhi. And you must have seen, I think, hundreds or maybe thousands of TBM. I've just one or two questions with you. One is, have you ever used thalidomide in cases of TBM, or you have not used? And secondly, what is the role of mannitol in cases presenting like this, headache, vomiting? So about these two questions, please clarify.
Thalidomide used, I think, in couple of patients that were long back, maybe like beginning of my practice, not in the recent past. And about the mannitol, mannitol is a decongestant, and unless we have edema, it is not going to work. So in a patient who has tuberculosis and edema around them, then mannitol is going to work. But if it is say arachniditis or granuloma without edema, it is not going to work because it is a decongestant. In a patient who has meningitis or arachniditis, steroids are the one which work as anti-inflammatory medication and avoid inflammation or fibrosis of the meninges. So mannitol has a role initially for 5 to 6 days, especially in the patient who have tuberculosis with lot of edema.
Thank you, Dr. Ish.
Dr. Ish, I have one question. These patients, like, do we follow up, amazing follow-up? How frequently do we get a CT head done for this patient? Because this can be really near life-threatening patient, which the patients at times insist the doctor that we need to see whether the tuberculoma has decreased in size or not. So how frequently should we advise radiological follow-up for this patient?
Like in a patient of TB meningitis, in the beginning, if you are syphilis, then you cannot do a MRI again and again. Like it's quite an expensive treatment. So if you take a patient of TB meningitis, if the patient is not recovering, patient is developing bradycardia, altered sensorium, increasing headache, vomiting, then we go for a CT scan sometime even every 7th day or so in the beginning. Otherwise, in a patient who has TBM, who is responding well to the treatment, I mostly go for an MRI with contrast after 3 months, and then sometime at 9 months or 1 year. But if the 3-month MRI normal, if the meningeal inflammation has gone, I do not repeat it. CT is a cost-effective investigation. So sometimes patient who cannot afford, we do go for the CT scan, but that will show us more of a hydrocephalus than anything else. In the patient who have tuberculosis, there the role of MRI is a bit more. One is you want to see the response to the treatment, or sometimes you have a tubercular abscess you want to see, or you have a patient who has say opticochiasmatic arachniditis, you want to see the response. In those cases, like I will do it in the beginning, do it at around 3 months, then around 1 year. And then in the patient who are not resolving, I do scans every 3 months. And when I see 3 scans not showing much change, like they do have tuberculosis, they are enhancing, you see a lot of meningeal enhancement, but if the 3 scans do not show any change, that is the time I stop the anti-tubercular treatment.
Thank you so much, sir.
Thank you so much, sir. Coming to Dr. Sumanlata, who is the state expert for this case. Ma'am, what would, this is a very successful model of public-private mix where you have a private hospital who's supporting the program so well. So what is your take on how these patients can be diagnosed at the field level, and how many, how can we get these facilities for the patients who are in the field? Yeah, you're audible, ma'am.
Yeah. Good afternoon, everybody. Thank you, ma'am, for giving this opportunity. Especially in such cases like disseminated TB. Earlier also we had a similar experience in one of the private centers in Hyderabad, where the presentation of the disseminated TB was over a period of 4 to 5 months. But in this case, in this present case, we could establish the disseminated tuberculosis in the medical college with the experts from various departments, and and we could get all the investigations done. So probably if we go as per the case, if it is a 17-year-old female coming to the emergency room with vomitings and headache, it was more of a neuro case, and our visions will be so tubular to go for a neurological management than to go for, unless infective etiology is anticipated. Then we go for the CT, chest, and all things have happened. But these things can happen only if we have that knowledge of tuberculosis could be a possibility, and medical colleges making utilization of all our diagnostic facilities which are offered free of cost. And like Mamta Medical College has a TrueNat, but they had sent this pressure samples of CSF and BAL fluids to IRL Hyderabad because their CBNet facility was very far off. So they sent to us for diagnosing the tuberculosis, and both the samples showed MTB detected low, and it was indeed at the same time we could get sample for first line LP, and that was also immediately processed. So more of commitment from all the departments, especially whenever we are putting whenever we are having core committee meetings at the medical colleges level, that actually they are very, as the meetings are more frequent, the availability of resources and making the resources being utilized can be taken care of in such settings. And that actually helped this 17-year-old female to diagnose as a disseminated TB at the earliest. That is one. Second thing is availability and taking the sample. It's not about only collecting the sample. Mitchell Malkajgiri has a good, robust system of sample transportation within the sample collected, and it's like within the vicinity of GHMC, that is in Greater Hyderabad Municipal Corporation. So the sample is immediately transported and to the IRL within a very short time. I think not more than 4 hours it took to get the sample to our lab. So that was, and that also really helps, to get the diagnosis. Third thing is, as and when we keep on meeting in a core committee meetings organized at every month in medical colleges, where NTEP and medical colleges, lot of knowledge sharing and experience sharing and cases like this can be discussed, so that more and more service can be delivered, and earlier diagnosis, which we are talking about, especially in such cases of disseminated TB, can be done at the earliest. So these are few things which I think should be taken up as a collaboration with the medical colleges and program. And when it comes to a private medical college or private center to a medical NTEP, the bridging gap should be made more feasible and accessible at both the levels, so that a confidence is built up with the private sector from the government sector, and services should not be stopped at any time from the public sector, so that private people will have more confidence in getting and clinching this diagnosis at the earliest.
Very well said, ma'am. And I think that's the carry home message for us, for the district TB officers, to have a very good coordination with their medical colleges and their private sector, where both of us can take responsibility for that patient and provide best services for the patient. Thank you, ma'am. That was very.
Nita, can I?
Yes, sir. Sure, sir.
Yeah.
Yes, sir.
So first of all, I want to say that there is no difference between a government and private colleges as far as the NTP is concerned. So services are equally available in private colleges and in government colleges. If there is something lacking in private medical colleges, then they can sign memorandum of understanding with the state office or the district TB office, so that these services can be accessed by the private medical college. So the facility provided in medical colleges, private medical college, if they so desire, they are just equal to the government medical college. So one query I have got. So as far as I know that intensive phase is not extended. So what was the rationale of extending intensive phase by 1 month in this case? That is my query.
Can I respond?
Yes, yes.
Sir, as patient had vomitings due to ATT also, sir. When we have started the intensive phase, after 10 days or so, she was coming repeatedly with vomitings. So we had to give proton pump inhibitors and also some antacids just to relieve her symptoms and to reassure that if she could have a proper diet without much of spice and all, and also some domperidone sort of medication, so that her vomitings could be limited. So in the time her 2 months of intensive phase, she probably lost whatever medicine she took because of vomitings, which happened around 1 hour of taking her medicines. So where she could say, I could see the orange color vomitus. So this was one of the condition where we thought maybe she had around 8 to 10 days of ATT, which did not actually go in. And the second thing was she had consistent headache, which we thought of tapering down 5 mg of prednisolone every week, but that also was very tough because as soon as the prednisolone dose was tapered, she had to come back in the next 2 days and complain very severely of headache, and she used to stop going to college because of headache. So with this, we could not taper down the steroid dose even in 2 months also. So, and as the CT showed residual lesions, which were not totally subsided, and also there is a lymph node, the reduction in size is not much. So with this, we thought maybe an extension of IP to 1 more month would help her. And that is why one of the questions was, we are not sure as if intensive phase is for 2 months or 3 months, and ATT with meningitis should be given for 6 months or 9 months. So, the guidelines also are not very clear on it as far as my knowledge goes.
Okay. Thank you, Dr. Rajiv. And we'll take that question again. STDC West Bengal wants to ask a question. Or his hand is raised.
Good morning, ma'am. Good afternoon, ma'am. My question is regarding the role of steroids that was discussed. So I would be very helpful if it is kindly discussed once more. In this context, the relation with apoplexy, which was in the suprarenal leading to hemorrhage and deficiency of steroids, that is the internal steroids. Is there a relationship with that? So I would like to be clarified on this matters, madam.
Yeah, Dr. Ishanand already spoke about steroid. Sir, are you still there, Dr. Ishanand? Yes, sir. Yeah,
like,
question for you, sir.
Yeah, steroids are so I would say they are the mainstay of treatment with ATT in a patient who has TB meningitis or a patient who has tuberculosis with edema. Because if you see a single tuberculosis without edema, patient presenting with seizures only, and you see mediastinal lymph node and you do a biopsy there and you find the TB positive, it's a single tuberculosis, there no need for steroid. In a patient who has developed ultrasensorium, is going down, has speech involvement, has multiple intracranial tuberculosis, has meningeal involvement, the inflammation need to be protected. Otherwise, these patients go into developing arachniditis, they go into developing this opticochiasmatic arachniditis, and the patient becomes more symptomatic. So steroids are sort of, I would say, life-saving in these patients in the beginning. When you start with anti-tubercular treatment, it takes, to my knowledge, up to two weeks before the ATT starts working in the brain. So in that time, you have to control the inflammation and you have to control the edema, and this is one of the best anti-edema measures, which has definitely has a side effect. Somebody has written in a patient who is cacaxic, who has low weight, has malnutrition, would you be like to give steroid or not? Like, these are the patients who are low in immunity, and these are the patients in whom the reaction may be very florid. the edema or inflammatory reaction, and definitely steroids are life-saving in these conditions. Especially in this patient became dull and drowsy within 5 days.
Yes, sir. Okay.
Thank you, sir. Thank you for taking.
Thank you, sir.
Dr. Singla, would you like to give your comments on this case?
Yes, thank you. You see, first of all, I would like to start with that as our director has already announced. With this clinic onwards, we have started a new initiative wherein we have asked all the our students as well as the senior residents to join the clinic, and this will be treated as one of the academic activity, like we have seminars, we have journal clubs. And Dr. Bhardwaj is there, chairman of the National Task Force. So I request Dr. Bhardwaj also that please disseminate this to all the medical colleges of the country. I find this is a very good forum for the postgraduate students and the senior students to learn. So please try for that so that we have this initiative again going to the all the medical colleges. Now coming to the this is our seminar room where the students are sitting. Now coming to the comments regarding the TB meningitis, right? And the treatment, Dr. Ishanand has practically said everything about this. Just for a repeat and just for the knowledge of our DTO colleagues, you see, as far as the Government of India goes, the National TB Elimination Program, what they have recommended is that 4 drugs, INH, rifampicin, pyrazinamide, ethambutol for 2 months. And they say here the ethambutol can be replaced by amikacin or streptomycin, and this is the intensive phase, and followed by the 3 drugs, INH, rifampicin, ethambutol for 8 to 10 months. That is what has been recommended in our the EPTB guidelines. Now you see, as was discussed, ethambutol has got very poor CNS penetration. So there is always a query in mind whether to rely on ethambutol as anti-TB medication in these cases of TBM, which can be sort of killing the patient, which can have a lot of permanent disability and complication. So the other of what has been discussed is the other option other than ethambutol include the quinolones like levofloxacin, ethionamide, which crosses the blood-brain barrier very well, and streptomycin. At least they are good when the meninges are inflamed. So regarding this controversy has been going on, and I remember when the EPTB guidelines for the country they were being framed in 2023 at AIMS, there were a lot of heated arguments between senior professors of medical colleges whether to keep ethambutol as the 4th drug or replace it with the other drugs. Although at the end it was decided that it would be ethambutol, but there was a lot of heated arguments and based on their own experiences. If you go by the literature, in 2010, WHO, they favored streptomycin over ethambutol. Subsequently, this CDC, ATS and IDSA guidelines 2016, they said enough evidence that ethambutol is okay with it. And WHO 2022 statement, they also favored that ethambutol can be a part of the treatment. Of course, they are always open to replace ethambutol by amikacin or streptomycin. And finally, our own EPTB guidelines, they recommend ethambutol, but they also say it may be replaced by amikacin or streptomycin. Coming to children, as such, the guidelines for children also they remain same. But we should also know, like the American Academy of Pediatrics, they recommend to replace ethambutol by ethionamide or streptomycin. Because why to replace ethambutol is one is again a poor CNS penetration, and secondly is the ophthalmic toxicity, which can be sometimes missed in cases of children. So that is in their mind. And there is again a 6 months regimen consisting of the INH, rifampicin, pyrazinamide plus ethionamide for children and adults. And this was compared with the conventional regimen. There is a systematic review meta-analysis, including more than 1,000 patients. They found when you use this 6 month regimen, including ethionamide in place of ethambutol, the participants had lower mortality, that is 5% versus 24% in the conventional regimen. They had higher treatment success, that is 94% versus 75% in the conventional regimen. But what they observed, more frequent neurological sequelae among the survivors. So again, we cannot say that the 6 month regimen is superior to the conventional regimen of 10 to 12 months. Next slide, please. Next slide. If you look at this slide, which is there in our EPTB guidelines, the conventional drugs like pyrazinamide, ethambutol, they have very good penetration. Pyrazinamide and INH almost more than 90-95%. Ethambutol has just 10 to 50% CSF penetration. Even streptomycin has low penetration, but in inflamed meninges, it can achieve the CSF concentration. Even rifampicin, some people may not be knowing, it does not have a good CSF penetration. But still, what they have observed is that it is higher than the MIC. So that way, the rifampicin plus, of course, it is a bactericidal drug, and it also it's a sterilizing drug. So that is another reason to retain rifampicin in the guideline for the treatment of TBM. When you look at the second line drugs, the linezolid, ethionamide, moxifloxacin, levofloxacin, they have very good CSF penetration. Even the cycloserine has got 40 to 70% CSF penetration. Again, the injectables, second line injectables, amikacin and kanamycin, they have less CSF penetration, but in inflamed meninges, it is observed that they can cross it well. Next slide. Then very important is how to manage a case of TBM once there is the drug resistance or MDR demonstrated. Again, this is an area where the experience, I must say, even among neurologists, is not very much, and still there are some doubts about what best regimen to be given. If you look at the individual drugs, among the group A drug bedaquiline, it has a lipophilic nature, so the CNS tissue concentration is better than the CSF. The studies are very limited. Only case reports are there who are talking about the bedaquiline role in TBM. When you look at the group B drug clofazimine, it is a highly protein bound, and any drug which is highly protein bound and less lipophilic, then the CNS penetration will be. So although it's a sterilizing drug among the group B, but it may not be a preferred drug. Next. Coming to delaminate, you see it is the first replacement drug to be used in a case of pulmonary TB. And what they have seen against very limited literature, that CSF penetration is only 15 to 20% of the plasma concentrations. But again, like bedaquiline, it has been found that the tissue concentrations are comparable to the serum concentration. Regarding fluoroquinolone, they have good penetration, and there is some literature that in inflamed meninges, moxifloxacin may be better than ciprofloxacin, which may be better than levofloxacin or ofloxacin. Regarding the carbapenem, we always feel that using them, but the CSF concentration is only around 10 to 20%, and it is said to be slightly higher for imipenem. So if you look at this, what regimen we should give? Among group A, we can choose linezolid and fluoroquinolone, and so specifically maybe moxifloxacin may be preferred. In group B, cycloserine may be preferred. Only issue is, as we all know, it has got its own potential for causing the seizures and some psychotic symptoms. So we have to be careful on that front. In the group C drugs, the drugs which can be used are pyrazinamide, ethionamide, the injectables like amikacin, they can be a part of the regimen. So if you look at the regimen in MDR-TB cases, we have the linezolid, quinolone, cycloserine, injection amikacin, pyrazinamide, and ethionamide. In case we are not able to use any one of them, then definitely we can choose from other drugs like bedaquiline, delaminate. These drugs can be chosen as a second option in such cases. And I must thank Dr. Ishanand again that he was here to guide us. And based on his experience, he has told us about the diagnosis as well as the management of CNS. Thank you, Dr. Ish. Thanks a lot. Thank you very much.
Thank you, Dr. Singla. Yeah. Are there any questions, Dr. Singla? Are there any questions regarding the treatment?
Can I ask the question? As we have seen the first line ATT, they all except rifampicin all have a good CNS penetration. So though the guidelines doesn't mention any role of high dose rifampicin, so can be high dose rifampicin be given to these patients? Does it help?
Yes, you see literature is there where they have used high dose rifampicin 15 milligram per kg, and some even have tried 35 milligram per kg in TBM, but they found the results were not superior to the conventional dose. So that is the literature today. But apparently, it appears that high dose rifampicin may have some role, but the literature as of today is not supporting this for CNST.
Thanks. Thank you, Dr. Singla. My question to Dr. Sumilata, ma'am. Ma'am, once the patient is diagnosed by a medical college or a bigger hospital, what are the instructions that are expected for the field, so that DTOs are able to manage the follow-up of this patient? What is
Yes.
expected? Yeah.
Yeah, ma'am. Our experience is like this, ma'am. So every medical college is usually having one TBHV, one lab technician, and few medical colleges have medical officer in position, but not all the medical colleges, because if TB health visit particular college is supposed to make visits to all the departments to for getting the TB tested in the facility of the medical college, either by designated microscopy or by CBNAT or TrueNAT facilities, either in the government sector or in the private sector. I mean, private medical colleges. So that is first step. And then second thing is, whenever a patient is coming to a medical college, he must be from a far off place, like he must be out of that particular district. So once the particular patient is enrolled in the medical college and his diagnosis is done at that medical college, most of the cases which are diagnosed, they would be, he would be sent with the treatment card. And in the WhatsApp group also, most of our STS usually, refer to that particular TU of that particular district and request them to accept. So I can sometimes show you that examples of like how they are transferring it out, so that there is no linkage loss of those cases which are diagnosed at the medical college and getting treatment at that other level. Suppose if that particular patient is belonging to the same district, the TU, the corresponding TU, STS and the medical college STS would share that information, and in no way that public health action is interrupted in any way. So the drug, initial drug dispensation and giving the drug and sending back the patient to their particular place, and if it is a different TU or a different district, that follow-up and transfer has to be done on a real-time basis. So sometimes this is very challenging in the medical colleges, which we have seen earlier, but that trend is just getting improved over years, because every day, whenever, especially in a large hospitals, large chest hospitals, where we do get per day 20 to 30 diagnoses of TB, especially in that cases, on all the 20 cases will not belong to the same district where the chest hospital is present. So out of them, at least 10 would be out of their particular districts, and the immediate transfer, real-time transfer, will make both the DTOs will to look into the data and follow up the patient and patients from out of state also, where we do communicate to the STO of that particular state through mail, and allow them to know that these cases which have been diagnosed here have been referred to that particular state. So these are few mechanisms we are doing. Suppose if there is any challenge in not getting this action being done, we were trying to make a list of those cases and okay. We are trying to make the list of those cases and ensuring that they are transferred and getting their care cascade at that respective districts or health facilities or near their health facilities.
Thank you, ma'am. So the message is very clear that there are mechanisms within the program that whenever a patient is diagnosed, whatever specialty, there is a linkage system from where the patient can go from that medical college or private hospital to the government health facility and get the regular treatment, and the DTOs would regularly follow this patient. So the treating physician should ensure that the patient gets into that system. Once you ensure, then the people will take it over. There's a whole team which works for it. The only thing is the treating physician should make sure that the patient reaches the referral center and patient is getting the regular treatment. Thank you, Dr. Sumanlata, for informing us that. Are there any more questions?
So there's one more question because we have come up with the poor penetration rifampicin. So there's a question on that. Do we need to replace rifampicin in case of first line drug with the second line drug, or we can continue with the first line drugs only if the patient is drug sensitive?
Yes, you see again, this question is logical. But what they have found is that the rifampicin, despite being, despite having poor penetration, but whatever level is there, it is higher than the MIs. That is one. Second thing, we know the INH and rifampicin, they are one of the most bactericidal drugs. In addition, rifampicin acts on the intermittently multiplying bacilli, so again, it's a sterilizing drug. So I think there is no confusion that rifampicin should remain as a part of the anti-TB medication for CNS TB unless we have a contrary evidence. So as of today, it should be retained. For ethambutol, yes, as we discussed, there are some controversies, but as of today, the take-home message is that the treatment for CNS TB is 2 months of both drugs, INH, rifampicin, and ethambutol varazanamide, where ethambutol can be replaced by streptomycin or amikacin if it is required, and then followed by 8 to 10 months of INH, rifampicin, and ethambutol. Another thing which I would like to discuss is that there was some discussion about the 2 months versus 3 months. You see, as Dr. D. Shanand also said, which I was noticing is, sometimes they extend for 3 months. Yes, the guideline says 2 months, that is, the guidelines are meant for the lakhs of patient. So in general, yes, we should stick to the guidelines, maybe say 90-95% of cases. But if you find the treating neurologist, you see they are the best judge. If the treating neurologist feels, based on the clinical assessment, based on the radiological assessment, that in this case, I would like to extend the intensive phase by 1 month, we should accept it. The program should not be rigid about this. Sometimes it is observed that the people in the program may object to it, that why are you extending? No. We should respect the opinion of a neurologist in such cases because they are much more experienced than we are in treating the CPTB cases. And I'm sure that all the neurologists who are treating this, they have their own experiences and they will do it only in cases where they are strongly feeling that this particular patient requires the extension based on their clinical assessment or radiological assessment or both. So we should be open to it. Thank you.
Thank you, sir.
Nita ma'am, with your kind permission, we have our DTO, Mitchell Malkajgiri, Dr. Sandhya Rani ma'am, here in the group. We can hear from her also the public health practices which are happening.
Sure, ma'am. Is she joining?
She joined, ma'am. She's there in the. Yeah, she's there.
Can you request her?
Yeah. Sandhya ma'am. Okay, ma'am. Go ahead. I think I am not able to reach her.
No issues, ma'am. So with this, we come to the end of the program. We are joined by Dr. Ashok Bharadwaj, sir. Sir is chairperson of the National Task Force, which is responsible for coordinating with all the medical colleges in the country. So I would request Dr. Ashok Bharadwaj to give vote of thanks.
So, thank you, madam. Thank you, Nita. Thank you, Rupak. So first of all, I must thank Dr. Vishwaman Katoch, because he right from the start, he's still there. So his opinion, his expert opinion matters in many things. So I was his junior in senior in medical college, but I always have in esteem because I have learned many things from him and still learning from him. So thank you, sir. Thank you. So then I must congratulate the team, Rajiv team, who presented this interesting case. So in such type of cases, so enlightened with many improved diagnostic facilities and the treatment facility. So thank you, Rajiv and the team and the local expert. So I will request that if there are any difficulty in Telangana, so STO Telangana, Dr. Rajesham is very proactive positive person, and you can contact him at any time over telephone or for any other purpose or email. So I have seen his working and he's proactive. I don't think there is any deficiency in any of the medical colleges in Telangana, whether government or whether private medical college. So they have made the arrangement also. So thank you all. So when Neeta, I was in Pune for West Zone workshop or review meeting of the zone NTP, so many people came forward say that yes, we want to contribute to the national TB clinic. So I told, I gave your name, then you sent that the case to Dr. Neeta Singla and or copy to me also. Request them, request her that she can take the case. I cited example of Karnataka also. So one query I got yesterday, madam, from Uttarakhand state that this is the time we have got active clinic. We are sitting in the clinic, not possible. So they had requested that our video recording are available for these cases. So that is mine. So thank you all. Thank you for giving me a chance, madam. I am definitely active part of your national difficult TV clinic. Thank you.
Yeah. So it's your clinic, it's a NTF collaboration clinic, so it is not NITRD, it's the NTF and CTD's clinic, and your constant presence has always encouraged us, you're always there to support us and you attend each and every clinic of ours. So thank you so much. Thank you, Katot sir. Thank you, Team Telangana, for being there, and thank you all the attendees for staying till the end. Thank you so much. And thank you, EPO team also, who's been supporting us throughout. There is a link sent on your mail for the feedback. Please give us the feedback about the clinic. Yeah, so video is already shared. I think it's put on the chat that it is there in your inbox so that you can always access it, right, Shifa? Yeah, so it's there. It's already shared. So thank you so much. Thank you.
Thank you, madam. Thank you, sir.